Hello everyone. Today we're going to be talking about the assessment of the GI tract. This is a brief review. You had the GI system when you were in health assessment class, so you are responsible for this chapter. This is just a brief review of the assessment of the GI system. The GI system can be thought of as a tube with necessary structures extending from the mouth to the anus for about 25 feet in length. The structures of this tube, then as you can see, these are shown enlarged here. Let me use my little cursor. Okay, is basically the same throughout the length. The functions of the GI tract are secretion, digestion, absorption, motility, and elimination. That looks like one of those review questions I would stick on a test. Assessment. Assessment, noticing and interpreting. You want to ask your patient about their history. Have they had changes in their appetite, their weight, or their stools? What do their stools look like? A lot of times people don't really want to discuss what their stools look like, but it's very important. Are they watery? Are they formed? Did they used to be formed and now they're watery? What color are they? Are they a light tan? Are they a dark brown? Are they black? All of these things are very important. What is the age, gender, and culture of your patient? Have they ever had any GI disorders or any abdominal surgeries? What medications do they take? Herbs, supplements? Do they have a history of smoking? Have they traveled anywhere, especially to foreign countries? What other health problems do they have? Do they smoke? Do they use alcohol? What is their caffeine intake like? Their socioeconomic status? Do they have any specific family history? It's important for you to take a good look at chart 52-2B. Okay? Abdominal pain assessment. When you're assessing the pain in the abdomen, you have to ask some certain questions. Is it precipitating? What is the quality or the quantity of the pain? What region is it in, and where does it radiate to? What is the severity? And when does it happen? The mnemonic for that is PQRST. So the P is the precipitating or palliative. What brings on the pain? What makes it worse? What makes it better? The Q is quantity and quality. How does the pain feel? Is it burning, stabbing, cramping, aching? Is it a full feeling? R, region or radiation. Where is the pain? Where does it go? Does it stay in one place or does it radiate up your back? Severity, think about the pain scale. Timing, what is the onset and how long does it last? Now, by this point in our journey together, surely you know that I like geriatrics, not overly, but I think it's important for us to know what the changes are as we age, what is normal and what is an abnormality. So it's very important for you to look at chart 52-1. So what are some of the things that change related to aging? Well, there's atrophy of the gastric mucosa, which causes decreased absorption of both iron and vitamin B12. Peristalsis decreases. Sometimes they have a decreased sensation of their need to have a bowel movement, which can lead to constipation and impaction. And it's also the reason that a lot of times our elderly patients are very infatuated with their bowels. They're very much, I take this, and this, and I drink a cup of coffee, and I do this because I have to have a bowel movement every day or every other day. They all have their regimens, and it is best that we just don't differentiate from them because they know what works for them. Okay? Age-related, again, is distension and dilatation of the pancreatic ducts, causing decreased fat absorption. Okay? They also have a decreased number of hepatic cells, so therefore they have a decrease in their enzyme activity. Again, there's a whole list of them there in chart 52-1, So it would behoove you to take a look at that. Now, moving on to physical assessment. As we remember from health assessment class, we start in that right upper quadrant and work our way around. Okay? So what assessment techniques should we use? Well, when you're doing an abdominal examination, you should start in that right upper quadrant. Remember, you inspect and you auscultate and then you palpate. And you do not palpate if you're ruling out an appendix or an abdominal aneurysm is suspected. And remember, only healthcare providers and advanced practice nurses, such as advanced practice nurses, perform percussion and deep palpation. Now that's what the book says, but now quite frankly, I would never do any deep palpation. But if someone is suffering from an ileus, where they have absence of bowel sounds and their belly has become quite rounded, it'll become quite tympanic. And a lot of times I'll do a quick tap to see where we are with that, to see if it's truly tympanic or what it's sounding like. So, I wouldn't go beating on everybody, but there are times I think where percussion can be done by a nurse. Now, that's not a question I would ask you because the book specifically states that's only done by healthcare providers such as advanced practice nurses. And I completely agree with that with deep palpation. There's no reason for generalists to be doing that kind of thing. Okay. Psychosocial assessment. Remember that patients may be embarrassed to discuss elimination problems. Ask how GI health problems affect their life, or their lifestyle, or activities, or even their employment. Ask about stressful activities that precede or exacerbate any GI problems they might have. Patients with cancer may experience part of the grieving process no matter what kind of cancer it is, including GI cancers. But for my purposes, the main thing I want you to know about psychosocial assessment is people are usually embarrassed to talk about elimination problems. And a lot of GI health, because it is it's very private, it really does affect people's life, their lifestyle and activities. So it's very important to discuss this with the patients who are having a lot of GI problems. Guys, here's an entire list of different diagnostic tests that are done when assessing the GI system. If you open, as I've told you before, always make sure you open up the notes section of my PowerPoints because it will give you a lot of information. Because each of those tests look for different things. For instance, amylase and lipase looks at acute pancreatitis, which you'll do more in 495. Bilirubin is primary a pigment in bile, and it's the evaluation of jaundice, liver, and biliary problems. So it's also important to look at the ELSA test, which is for C. difficile, and it can give you results back in as little as 2 to 6 hours. Remember the x-rays look for masses and tumors. Other imaging is a barium swallow. The liquids are chalky white. And after they've had a barium swallow, they'll usually have white chalky stools for the next 24 to 72 hours. Okay? But all of those are listed in a lot more detail just in that notes section. Again, this is a review for you, but I did want to make sure that you did take a quick look at those. I think it's important to know when physicians order different tests, why they're ordering them. Lastly, we're going to talk really briefly about a colonoscopy. It's an endoscopy exam of the entire colon. It is recommended every 10 years, greater than age 50. If they're greater than age 50, if there is no relative or family history. The prep is that they're usually on clear liquids, but they want you to avoid usually red, orange, and purple because it can make things look more bloody. Usually they'll stick with greens and yellows. They're usually MPO 4 to 6 hours prior. A lot of times they'll take they usually will take some type of oral prep to cleanse the bowel. They have different stuff now. They used to have this stuff back when I was working med-surg more, called Go Lightly, which was kind of an oxymoron because it made the patients cleanse their bowel. I just have always found that humorous. They use different things now, but Go Lightly was one of the things I used to use back in the 90s. And it's just funny that it was called Go Lightly and it was to cleanse the bowel. Anyway, on with that. With the procedure, they're generally on their left side. They'll make sure that they have IV access, and they're given a moderate sedation. In some places, they call it a twilight, where they can still follow commands, but they don't really care what's going on. And they usually don't remember the procedure. That's why they call it a twilight sedation. That wouldn't be on a test. I'm just telling you that's what they call it. Post-operatively or post-procedure, you do vital signs for about every 15 minutes until they're stable. And once they're passing flatus, they can start having fluids. All of this is listed very nicely for you in chart 52-4. Again, this is just a brief overview of the assessment of the GI system.